So I'm a vascular neurologist at Harborview, and so I primarily treat patients that suffer from strokes or from intracranial hemorrhages. I also attend on the inpatient wards, meaning if someone gets admitted to the hospital and they need to be cared for by a neurologist, I also do that. And so in that way, we see other types of neurological conditions like seizures or brain tumors or other neurologic problems that require hospitalization. I'm also a clinician-educator, so I work very closely with our residents and our medical students, and part of my time is spent taking care of patients, but the other part is spent talking with medical students and helping them learn how to talk to patients and how to do physical exam and basically how to be doctors. So the field of palliative care has been around for quite some time. And most of the work in palliative care actually started in the cancer world. And there's been lots of papers published, physicians who are training to become hematologists or oncologists, those doctors that take care of cancer patients. It's integrated into their residencies and their fellowships, how to do these skills, how to talk about end of life, how to talk about an advanced care plan, for example, or an advanced directive. And although doctors in many other specialties deal with patients that have serious chronic illnesses or have end-of-life care issues, it's not really as integrated. And you might imagine that a cancer patient who gets a diagnosis and has, 6, 8 months, 1 year of time, those conversations are a lot different than a patient who all of a sudden went from being completely fine to completely affected by a neurological condition. And so the parameters of what needs to be done and what conversations need to be had and what goes into the decision making is a little bit different in those situations. I'm particularly interested in this acute brain injury aspect of palliative care, neuropalliative care, but you can imagine for patients with dementia, for example, for patients who have Parkinson's disease, all of those patients also can benefit from palliative care. So neuropalliative care is really about expanding those indications just from cancer to some of these other things. One of the commonly utilized resources in palliative care is something like hospice. So if a patient is expected to pass within the next 6 months of life, they potentially could qualify for hospice. There are lots of other criteria, and insurance companies have a lot to do with what those criteria are. Many patients who do suffer from conditions that are serious, that have neurological indications, actually don't currently meet criteria to be included in hospice. And that's because there's a poor understanding of what those patients need and how to support them. And so again, we're just trying to increase the awareness of this. Neuropalliative care is a relatively new field within the field of neurology, and it's emerging, and I'm excited to see what happens in the next several years. I think exposure is the main thing, which is why I love what you guys are doing here. Many people don't even know, right, that neurology is a field and that we as neurologists can actually affect change. A lot of what I heard when I was a medical student, I was thinking about what specialty could I go into. When I talked to folks who were not neurologists, there was a lot of doom and gloom. Why would you go into neurology? Like, nothing gets better. But that's not true. And so I think just understanding that there are options out there and that there are a variety of people that go into fields like this. It's not everybody is not at the bench, right? Everyone doesn't have a bow tie, which is like the classic old school description of what a neurologist looks like. And so I think really just that exposure and starting that exposure from sort of a younger age, from a younger standpoint, so that people are prepared and are in the position where they could go to medical school, or they could go to dental school, they could do some of these things because they've been working towards that already, and it's not just a last minute kind of, all right, well, let me take the MCAT, let me figure out how to do this, because that's not going to be as effective as if you were thinking about that throughout your career in undergrad and sort of making a path towards that and learning more information about it. I think there is, and I think it's partially, at least with at UW, us neurologists kind of trying to integrate the medical school a little bit, or infiltrate the medical school a little bit more. And so my work in the colleges program, which is the mentorship program where we kind of teach students how to become doctors, just being there gives them an option like, oh, okay, well, Dr. Taylor's a neurologist. Let me look more into that specialty. So just that presence, I think, does have a lot to say. Many schools actually don't even require neurology. Many medical schools don't require neurology as a specialty that you have to rotate through in order to graduate. Or if they do, it's often a specialty that folks rotate through in their last year when they've already kind of made a decision about what they're going to go into or what kind of doctor they're going to be. And so from my perspective, I think it's crucial to sort of, again, try to infiltrate those earlier, more impressionable minds in terms of seeing that this is an option. Yeah, there are a lot of programs targeted towards trying to reach students who are in middle school and high school and undergrads as well. One of which, Dr. Stella Williams, who's a general surgeon at the University of Washington, has come up with this program called Doctor for a Day, which specifically is targeted towards elementary and middle school students from underrepresented backgrounds. And they do actually a variety of different subspecialties. On weekends, it was in person before the pandemic, but it's been on Zoom for the last couple of years. And they basically just hear from doctors and from resident physicians who are in those fields, and they do things like brain dissections. For the neuroscience day, we actually did a mock stroke code with them. So we had one of our fellows pretending to have a stroke, and we had the students on Zoom kind of calling out what were they seeing and what did they think we should do. We had them looking at slides of what brain cells look like. And many of them were so excited just to have that exposure and see like, oh, this is a pathway that I could actually take. There are people that look like me that are doing these things that are really, really cool. And I think, so it's really great. I love hearing about any sort of like outreach stuff or kind of early exposure that's happening. So I went to medical school, I went to undergrad and medical school at University of Illinois in Chicago. And University of Illinois, the Chicago campuses especially, are a bit more diverse in terms of the physician workforce there. University of Illinois is probably one of the more, or at least at the time I went there, was one of the most diverse medical schools outside of the historically black colleges and universities. And so I felt like I did have, or I did at least see people that looked like me that were in these really impressive fields, that were, deans of schools of medicine, that were, chairs of departments, etc. It was a bit of a culture shock, actually, when I moved here, and I was one of very few underrepresented minorities that were in my program. And it was hard to kind of find community, actually, in the Seattle area in general. And until I found that part, I sort of felt like, oh, I don't fit here. But I liked my patients, I liked what I was doing, and so it was kind of like, well, I'm going to be here regardless of whether or not people want me to be or not. And that resulted in me being hired on as faculty, and everyone was really, really supportive in my department of kind of really helping me carve out my own path for something that really hadn't been done in our department in terms of, my interest in neuropalliative care and also medical education. And although that wasn't what they were maybe expert at, they were expert in helping me figure out what steps do I need to take to get there. And then when I was hired, I think I was probably one of the first black physicians to have been hired on faculty at the time. And now our second black physician is actually the chair of our department. And so I feel like, there's been a lot of focus recently on improving diversity within medicine in general, but certainly at the UW. And I also feel like it's genuine from our department, and so I've always felt supported. I think there's always a little bit of, oh, you look young, or oh, you're black, or oh, you're a woman, that sometimes causes people to prejudge you, especially from patients sometimes. I'll walk in and they'll assume that I'm the nurse, or they'll assume that I'm there to help change the bed, even if I'm in my white coat and I introduce myself as Dr. Taylor. And that used to bother me a lot when I started. Now, I feel like I choose whether or not it's worth it to really address it or make a big deal about it, because at the end of the day, what I'm there to do is to take care of this person, to take care of this patient. And so usually, you know, politely educating them about what my actual role is on the team. Many people, especially nowadays, I think get a little bit embarrassed when they realize they've made a mistake. And my intention is not to embarrass anybody, right? But also, we should be not making assumptions. We should be thinking about everyone in the space on an equal level, and therefore you would make that assumption if that were the case. And so I think, you know, again, this presence and representation and people seeing something that looks different or seeing something different than what they're used to and realizing like, oh man, she's still an amazing doctor despite the fact that I had these other assumptions about what, you know, she might be like, changes the narrative. And so it's a slow process, but I think it's happening.